Welcome. Thank you for joining us this evening. We are here to tell you a bit about diabetes. Tonight, I'm Dr. Fran Broyles. I'm an endocrinologist.
And I'm Jan Rystrom, and I'm a certified diabetes educator.
Okay, well, thank you all for bearing with us today. We had a little bit of technical difficulties, but here we are ready to go. So to start off, let's ask a couple questions related to diabetes. Who is most at risk for diabetes?
It's a great question, and I would just point out that if you're concerned about whether you may be at high risk, you can go onto the American Diabetes Association website and take a 60-second test to assess whether you're at high risk for diabetes. And really the issues that we're concerned about is if you're carrying extra body weight, and that's actually defined by something called body mass index, which is height versus weight. So if your body mass index is over or equal to 25 or over 23 if you're Asian, if you have a first degree relative with diabetes, your mother, your father, a sister, a brother, if you're of a high risk ethnicity group, which includes African Americans, Latinos, Native American Indians, Pacific Islanders, and Asians, if you are inactive, if you had gestational diabetes, those are some of the major risk factors that we are concerned about. High blood pressure, high cholesterol can also play a role. And so those individuals were concerned about having higher risk for the development of diabetes.
Mm-hmm. Great. I just want to invite everyone that's tuning in. Thank you for answering that question.
Yeah.
Everyone that's tuned in, if you'd like to ask any questions, please feel free to put them in the comment section or send them via private message. So let's move right along to the next question. When should I be getting regular screenings for diabetes?
Yeah, so I think that the issue for that is that currently the ADA recommends that anybody who's over the age of 45 should be tested for diabetes. Mm-hmm. In addition, if you have high risk factors, then testing for those issues sooner makes sense. Jan, do you have any other comments on that?
Yeah, well, and I think certainly if you're pregnant, you will be screened for diabetes in your pregnancy starting about week 26, 28 to make sure blood sugars are in a normal, safe range.
Great. And another question that we had from before the live, when should preventative measures start being taken to prevent diabetes?
Oh, that's a great question. I'm gonna let Jan speak to that to a large extent, but I would just say preventative measures apply to all of us in the population in mm-hmm. terms of making healthy choices with reference to exercise, nutrition, and stress. But Jan, do you have any comments there too?
Well, I do, because diabetes is, let's face it, epidemic, not mm-hmm. just in North America, but around the world, as we have this wonderful food security now. People, are, for the most part, are not starving, but we have diabetes showing up everywhere and at younger and younger ages. So I am an advocate for diabetes prevention starting in the womb, basically, with mm-hmm. pregnant moms having healthy diets and activity, and modeling that for their babies and children, and for school lunch programs, promoting healthy food, and exercise programs for all ages of people. I don't think there's an age at which we should say it's now time to start preventing diabetes. We mm-hmm. need to start it right away. It needs to be our lifestyle.
I agree.
That's my soapbox.
Yeah. Exactly.
Yeah. Absolutely. So what would you consider like a healthy diet, and what are some things to maybe avoid?
Oh, well, now you got me going. So a healthy diet is a diet that is enough calories to meet your needs, whether you're a growing child or an active adult, but not so many that you store those extra calories as fat. It's a variety of foods, so you get a variety of nutrients. I very much promote a plant-based diet of locally produced foods, organic as much as you can afford them. We need unprocessed whole foods in their most natural condition. And that's saying a lot, because we have busy families. We don't have a lot of time for processing food, and yet that is the most appropriate way to do it.
Mm-hmm. And I would also say that, if choosing wisely and knowing what to eat were easy, we'd all be doing it.
Mhm.
And there are many things that keep us from doing that, including things like our busy lifestyles, fast foods, things that are easy to grab. But I would emphasize that meeting with a dietitian to get insight into how to make those changes can be exceedingly helpful. And so that's something that I think would be heavily emphasized by us as well, to make sure that you get the information that you need and you get accurate information. There's a lot of information out there that isn't so accurate.
But also I think it's important when we meet with our clients, we really work with them where they are starting at. So if you are a person who has a busy family or on the go a lot, both whatever parents are in the house are working away from home, it is hard to take time to do menu planning and shopping and food preparation. But it can be done, and that's something that we can help you with is where are you at? What maybe sort of partially prepared foods from grocery stores can be helpful? How can we create a healthy meal plan for families that will work given all of the stresses that we have?
Yeah.
And I have to say to that point as well, we really are also, we meet people culturally where they are. Certainly we know that different cultures like to eat differently, and food is a very important social gathering for people. So it's a really critical piece of our lives. And oftentimes we start by just asking you to make one change. Can you give up sugar beverages? That can be, in some people's lives, 500 calories a day. So I think those simple steps are sometimes things that we give as tools to get started.
Yeah, great. So we actually have a question from someone that's tuned in live. What are your thoughts on intermittent fasting?
So intermittent fasting is one of the strategies that is being used a lot. I have a lot of patients that are trying it. I think that there is certainly some benefits that have been shown by allowing the blood glucose levels and insulin levels to reduce to normal after meals. This can be very helpful. I will say that there isn't great data about it. There's been small studies, a couple of compelling studies. I mean, there's some very interesting anecdotal evidence. I don't necessarily recommend it to patients, but we certainly do talk about that, and for people who find it's useful, we certainly incorporate that into their strategies for diabetes management.
And I certainly would also add the following, that for people who have overt diabetes, fasting is not without its issues depending on the medications that you're taking.
Right.
So if you have medications on board that actually cause low blood sugar reactions, you have to be very careful about intermittent fasting or fasting in general. To the point is, as cavemen, we didn't eat, 16 hours out of the day. Currently the point is that, in the American population or worldwide, rarely are we going without food for oftentimes much more than 6 hours. People don't sleep enough. They're up all night. They're eating. So, eating in a more healthy pattern, irrelevant to fasting, is also something I think that's important. But there is a lot more science data that'll be coming down the pike on this.
No doubt.
Yeah. So would you recommend, if someone decides to experiment with intermittent fasting, that they should be looping in their doctor before doing anything like that?
Certainly if they have any chronic disease states, specifically diabetes, on medications that may affect their blood sugars, I think that would be very important to have a conversation about that.
Yeah, and can we talk a little bit about prediabetes? Now, what does that mean, and what can be done to kind of reverse those effects?
So prediabetes is the state of abnormal blood sugars that typically predates the diagnosis of diabetes by about a decade. And what we know about prediabetes is that your pancreas, the gland in the body that puts out insulin, has already started to fail at that point. So about 25% of pancreas function, insulin production, is gone by the time you develop prediabetes. At day one of diagnosis of diabetes, about half your pancreas is gone. So it's a time frame where we really, really want to intervene, both with nutrition and activity, but also oftentimes, with medications. So it is a critical time frame. The diagnosis of prediabetes and diabetes is made on the basis of blood testing. And so certainly for individuals who have, for instance, first-degree relatives with diabetes, we would potentially pick up pre-diabetes long before we would pick up diabetes in those individuals. Do you have any other thoughts on that?
Well, I think what's really exciting about pre-diabetes is that, number one, it is actually a diagnosis. It isn't like, I hear people sometimes saying, well, I was told I had borderline diabetes or a touch of sugar or any of these sweet euphemisms. Pre-diabetes is a diagnosis. And more than that, a very, very large, very well-designed research studies showed that changes in diet, a small amount of weight loss, small amount being only 5% of the body weight, changes in diet actually reversed the trend. So people did not convert from prediabetes to diabetes. That was very powerful. And in fact, we have very good programs now, diabetes prevention programs, to help people to get on the path and, as I say, turn the bus around so that they don't develop type 2 diabetes.
That's great.
Correct. And I think the other point is that we do know that complications that you develop with diabetes start to develop in the pre-diabetic phase. We used to think that that was not the case, but we have definitive data now that kidney disease, eye disease, nerve damage happens in the pre-diabetic arena. But again, to Jan's point, we can help to reverse the abnormalities in blood sugars and reverse the trend if we act at that time.
Great. So for someone to be diagnosed with prediabetes, they would go to their doctor, or are there some physical symptoms that would maybe someone would start to notice if they're pre-diabetic?
So not really. And that's the problem with prediabetes is that there really aren't symptoms. And so it really would be an issue of going to your physician to be tested. And I think also being proactive. My mom had diabetes. I don't want to get diabetes. I want to be tested to see whether I have anything to suggest that my blood sugars aren't normal. So that is something that we really, I think, challenge people with our diabetes education program to take control of their own health, to give them the knowledge and the power to make changes in their lives and to do the things that they need to do. So I think we really try to encourage them to proactively ask for things and go to their docs.
Right.
Great. Awesome. So we have another question from the audience, and you kind of started to talk about this a little bit already. Do you believe it is possible to reverse diabetes?
So that's a very interesting question from a semantics issue. So we cannot grow back insulin-producing cells in the pancreas. So once you have diabetes, you have already lost a portion of your pancreas. We can't restore that. However, if indeed we make some lifestyle changes, weight loss, change in nutrition, activity levels, we can actually restore normal glucose levels by decreasing what's known as insulin resistance. So weight loss and exercise powerfully reduce insulin resistance, and therefore you can have normal sugars in the setting of not as much insulin production, which is, the study that Jan was referring to earlier called the Diabetes Prevention Trial was a trial that looked at that, as well as something that was called the Look Ahead trial. And so we do know that if you can make some lifestyle changes and, potentially medications, that you can actually normalize blood sugars and put what we say, we like to use the term diabetes remission as opposed to diabetes reversal.
Okay.
So remission is really the better term.
And this is probably a good time to make a point that what we're talking about is specific to type 2 diabetes or insulin-resistant diabetes. This really is not a relevant conversation to talk about for type 1 diabetes, which is a completely different type, the autoimmune mediated diabetes. Would you say a little more about type 1?
Yeah, so what's interesting is 90% of diabetes on the planet is type 2 diabetes. Type 2 diabetes is the diabetes we think about getting at an older age, associated with carrying extra body weight. Type 1 diabetes is an autoimmune attack on the pancreas, the gland that produces insulin, destroying the ability of the pancreas to produce insulin. And it is the type of diabetes we usually associate with children getting. What we know now is that type 1 diabetes can actually develop at any age. It can develop at the age of 65. And type 2 diabetes, which we used to never see until people were over the age of 35, we are now seeing in children because of the obesity epidemic. So to Jan's point, we know that lifestyle modification is a powerful tool in type 2 diabetes with insulin resistance, but we can't, at this stage of the game, alter the immune attack on the pancreas that happens with type 1 diabetes.
Okay. So someone in the comments brought up the ketogenic diet.
Yes.
Can you speak to that a little bit? Because I know that intermittent fasting is a part of the ketogenic diet, but can you kind of speak to that and if that's something that you recommend for patients with diabetes?
Absolutely. I'm going to turn it over to Jan, who has been one of the dietitians in our program who's been instrumental in the development and implementation of the ketogenic diet for our patients.
Great. And this is such a fascinating place of looking at what all the dietary guidelines have been over the last few decades. And the ketogenic diet, as people may know, was a sort of a happy accident discovered that by using a very high fat, very, very low carbohydrate diet in children, especially children with epilepsy, it reduced seizure activity because of the way the brain can burn ketones, which are left over from burning fat. And so it was very happy. It was a wonderful treatment. And for many years, a ketogenic diet was used therapeutically for children with epilepsy. Well, then came along Dr. Atkins, who also promoted a very low-carb diet and again discovered that people using a fair amount of protein and a fairly high-fat diet completely counterintuitively dropped weight, their blood pressure improved, their blood cholesterol normalized, and their blood sugars normalized. And as we probably know, that had a very long history of controversy in the medical field and certainly was not ever promoted by the American Dietetic Association, now Academy of Nutrition and Dietetics, nor the American Diabetes Association. In our clinic for the last year, we have developed a medically supervised ketogenic diet, which is very low carbohydrate, very high plant-based. We're using a lot of vegetables, lean proteins, and very healthy unsaturated fats with pretty remarkable results.
Staggering results.
Right.
I would certainly say this is the diet, and again, I can't emphasize enough how wonderful it has been to have Jan involved with the development of this. And I think the issue with this diet approach has been the ability to see staggering results with blood sugars. We have these devices called continuous glucose monitoring devices now, and we see amazing and remarkable results there. We just had a patient recently that went on the ketogenic diet, lost 70 pounds, came off all of their diabetes medications, blood pressure medication as well, and has a hemoglobin A1C, which is one of the tests for diabetes, that has normalized. So again, this person doesn't have reversal of diabetes. Their diabetes is in remission, but it has been a highly effective approach. And I think, it's interesting to get Jan's comment on it. People aren't hungry on these diets. They really have good satiety typically.
No, and I think that's when I'm explaining the diet and teaching people how to use it. And of course, I want to stress that we do this in a very medically supervised way. We are monitoring blood sugars. We are adjusting medications and insulin. We are bringing people back for lab work. So we are very much paying attention and adjusting the diet and medications as needed. This is not a
we do not advocate doing this in an unsupervised setting.
No, we don't. But it has been quite remarkable to see these really astonishing results. And one of the things that people always ask when I'm first teaching them and we're calculating what their macronutrient distribution should be is, well, what am I going to eat for snacks? And I sort of laugh a little bit and say, well, here's some ideas. And of course, what it turns out is they really don't need snacks.
That is correct.
Now, that said, we are very interested to see what the sustainability is of, and I'm not calling it a ketogenic diet, frankly. In our instructions, it is a low carbohydrate lifestyle. My position is that people understand that while this is not a short-term intervention, it is a lifestyle, and all of the benefits of the weight loss, blood glucose control, blood pressure control will be lost if they resume what their previously typical diet was. So it really is developing a lifestyle, and I think therein is the challenge of how do we do this, as I say to my clients, every day for the rest of your life. how do we do this? We have to make this work.
And I was trying to say in the type 2 diabetic world, virtually all patients struggle with weight. And if weight loss were easy, we'd all be thin. The issue is that weight is a disease, just like diabetes, just like hypertension. And it involves a multi-pronged approach. But I do feel like we do, for people who are interested in ketogenic diets, we meet them and look at how they're eating currently, and they may not be appropriate for a full-blown ketogenic diet. We may just want to reduce their carbs by 30% or 50%, as opposed to pushing them all the way to ketogenic, and they can still see very long-term success with those.
That's great. Exciting. And when you talk about high fat, when I hear about the ketogenic diet, I just see butter and bacon and all these like meats. So what are some examples of those healthy fats that you were talking about?
So we work very hard with people to incorporate the unsaturated fats. So cooking with olive oil and peanut oil and using avocados on salads as a fat source, and very much limiting the saturated fats. This is not the old Atkins, butter up your bacon diet. So again, it's very much plant-based, plant-forward. I have a couple of folks who are vegetarians. We're using plant proteins, and very doable. Again, the piece that is important for people to understand is they have to be willing to plan it. They have to do some shopping. They cannot be strangers to their kitchen. And so it takes a little bit of work to be successful with this. And I've worked with a few folks who, after talking about it, said, "Oh my goodness, there's no way I can do this." And so we did a modified low carbohydrate diet for them that is actually having pretty good success.
Great.
Yeah.
Awesome. So we have another question from the audience, and I apologize if I say this wrong, but the question is, what about diabetes LADA 1.5?
Yes. So that alludes to the issue. LADA stands for late onset autoimmune diabetes.
Okay.
So again, that's going back to this autoimmune diabetes, which has been known as type 1 diabetes. And so late onset autoimmune diabetes is really the autoimmune form of diabetes that is diagnosed, if you will, over the age of around 25. So if you are diagnosed with diabetes after that age, we can test you for antibodies for type 1 diabetes. And if you test positive for those antibodies, then you are indeed late onset autoimmune. Type 1.5 diabetes is sort of an interesting image that is going to be changing with the American Diabetes Association. So type 1.5 is sort of, if you think of it, a sort of midway between the two. You have positive antibodies for type 1, so you have an autoimmune issue going on that's affecting your pancreas. And then you also have insulin resistance, which may be the result of you having a family history of type 2 as well. Carrying extra body weight and then having antibodies that show that you are having an autoimmune process as well.
Okay. Great. And another question that we have, can type 2 diabetes transition to type 1 diabetes?
No.
Okay.
So there's a sort of misnomer out there, if you will, that once you go on to insulin therapy, you have become a type 1 diabetic. And that is not true. It is true that type 2 diabetes, which leads to progressive loss of pancreas function, i.e. insulin production over time, that many patients with type 2 do end up having to go on insulin eventually. But it doesn't change the type of diabetes they have.
Great. So I'd like to invite anyone in the audience with any more questions to get them submitted, because we will be wrapping up soon. But another question, what is gestational diabetes?
Jen, you want to take that?
Gestational diabetes is the form of abnormal blood sugar that shows up during a pregnancy. Have diabetes, but in their pregnancy, due to hormonal changes and weight shift, they may have some abnormal blood sugar. It is typically screened at week 26 to 28, and there is a glucose challenge where the mom drinks 75 grams of glucola, which is sort of orange
delightful,
goo.
sugary, horrible drink.
Yeah. But in a fasting state, and then blood glucose levels are measured at intervals to determine whether the mom's body is able to keep up with enough insulin to bring that blood sugar back down to normal. If not, if they screen positive for gestational diabetes, then we treat ideally with exercise and with an appropriate diet. We help that mom to have a successful pregnancy, which means a baby of normal birth weight that is under 9 pounds without any other complications, and baby has normal blood sugar after birth. Those moms, by the way, do have a risk of going on to develop type 2, but also type 1 diabetes later in life. So in a way, it's a little bit of a heads up that maybe there is that gene for diabetes lurking in the background.
And there is a recommendation that women with gestational diabetes be routinely screened for diabetes for the rest of their lives. There also is a recent shift to say that because diabetes is and obesity is so prevalent now, that every woman at the time of becoming pregnant, if they have the risk factors for diabetes, should be screened at day 1 of pregnancy. If they pass that screen, then as Jan spoke about, they will be retested between 26 and 28 weeks.
Great. So we're going to have one more question, and I'd like to remind the audience that if you have another question that you see after the live is over, feel free to submit that question and the doctors will get back to you. So the last question, you mentioned diabetes education programs here. So is diabetes education and self-management education important, and where is it offered? Can families attend education sessions, and is it covered by insurance?
Yes, I'm going to hand it to Jan, who is one of our stellar educators who helps to run that program. It is absolutely critical for the long-term success of managing diabetes. And I think if there's a lot of misconceptions about what it entails, it is an incredibly empowering process. Jan, if you want to sort of overview what we actually cover, and yes, family is absolutely always welcome. We encourage family and even just whoever your support is to come in and learn about the disease.
Right.
Yeah.
Well, so, and in fact, that leads me to say, we've talked about type 1, we've talked about type 1.5, we've talked about type 2 diabetes, and there's sort of another group that we call type 3, and that is the family and friends of people who are supporting a person with diabetes. And so we definitely encourage those type 3 folks to that a person will have with a certified diabetes educator, and that could be a registered nurse or a registered dietitian who is certified as a diabetes educator. And then we have group classes that cover the range of what is called the core curriculum from the American Diabetes Association, or the 7 behaviors that have been identified by the American Association of Diabetes Educators as fundamental to self-management. As Dr. Broyles said, this is all about self-empowering people to understand how they are managing their diabetes, how to prevent long-term complications, but also to advocate for themselves for the best care that they can get. And there is a standard of care, that's capital S, standard of care for people with diabetes for surveillance and prevention of long-term complications. These programs are covered by insurance, including Medicare and Medicaid. They are offered at most larger organizations and clinics. Certainly Swedish has an ADA certified diabetes education program. And again, we invite family and friends to participate.
Yes, and I would certainly say that it is, as Jan mentioned, the standard of care for anybody who has the diagnosis of diabetes to get diabetes education. And again, that's why I think insurance coverage is so important. We do offer it on multiple campuses. So First Hill, Issaquah, Edmonds all have diabetes classes and one-on-one education. So it is something that we try to make easy for patients to attend.
And I have never had one person come out of the classes saying, oh, I didn't really get that. Everybody says, oh my gosh, I learned so much. I had no idea. I didn't know what I didn't know. And so they really are very comprehensive and cover everything from, of course, diet and how to check your blood sugar and how to take medications and how to exercise safely and what to do if you're sick. We cover all of those kinds of issues. So it's pretty empowering.
Yes,
That's fantastic. Well, thank you both so much for joining us today. Is there anything else you want to share with the audience before we wrap up the session for today?
So I think the main thing that I would share is that, diabetes, yes, it's a disease. Diabetes, yes, can have multiple complications, and it can be very overwhelming and depressing to get the diagnosis. But I want to encourage everybody who's listening to say that you don't have to feel overwhelmed. You don't have to feel like you can't make a difference in your life and take charge of the disease. We have a team that is, for one, that is very dedicated to making everybody with diabetes successful in managing their disease and preventing, hopefully, complications. Jan, do you have anything?
Well, no, I completely agree with that. And as I remind my clients every single day, every small change makes a difference. Every small change is important.
Absolutely.
Yeah.
Well, great. Thanks again to all of you, and thanks for everyone tuning in today, and hopefully we'll see you at an upcoming Facebook Live.